Okay, hold. We're recording now.
Okay, good. Okay, so we're gonna, record some of our thoughts and feelings about the ATTRACT trial, but I want to preface this by saying, Suresh, any of the questions and or some of the answers that may be given during this, I just want you to understand it's not a direct thing towards you, whether there's controversy or not. It's just I wanted to use more of the ATTRACT trial and your great work to as almost as a stepping off point as to what we may think about in the future, and also clearly what we have learned and maybe what we didn't learn from the trial itself. So don't take it in any other way, and that I kind of want an open discussion and not the usual. Here's what the trial did. Here's what it said. Okay, thank you. We're done. You okay with that?
Great.
Good. Okay. Do you want to start out? Or you want no? So, I really want to first ask you all what. Let's do it this way. What did the ATTRACT trial not tell us? What did it not tell us? And if you could remember, we're talking about for our readers here what we all feel it did not tell us. I know we want it to be positive, but I want to start out with what it didn't tell us at all. So, anybody want to jump in? If not, we have to start picking on people.
Yeah, I can start if you like. I mean, I think
Bill, I was going to pick on you anyhow. So go ahead.
Were you really?
Yes.
Okay. But I think the thing is, any prospective randomized trial, it's always going to be a narrow set of things that it's really going to test. And so all we know from this trial is that all patients essentially with DVT from the femoral up through the iliac cannot be told that they'll do better if they're treated with pharmacomechanical lysis. That's really the sole major outcome from the study.
Right, but Bill, that's what it told us. What did it not tell us?
Doesn't tell us anything else.
Raghu, anything that it did not tell us?
What it did not tell us, I believe, is the interaction of cardiovascular system as a whole. I believe that when you take Villalta score and probably apply that in congestive heart failure clinic, probably you'll get a ton of positive numbers in that too. What it did not tell us is whether these results are applicable for patients who are morbidly obese. What it did not tell us is whether a bunch of these people, or whether someone with DVT and concomitant superficial venous insufficiency, have any benefits with this. So yeah, there are several, like Bill said, it showed one, but there are a lot of other things it did not tell us.
Darren?
Yeah, I mean, I think that all of us probably in our practices have been convinced that there have been patients we've had who have benefited from pharmacomechanical thrombolysis, patients with severe proximal DVTs. So although in all comers the way the trial was constructed from femoral all the way up through iliac, you could not show a benefit versus medical therapy. What it didn't show us is that since we all believe there are some patients who benefit, to which subset or population of patients may benefit, that we should continue to look at.
Yeah. All right. So, and Suresh, you have the last word on this one.
Sure. So, well, I can address a few things here. So first of all, we did, without a doubt, additional detailed subgrouping and analysis of certain groups of patients it's ongoing right now, and we'll be having that data later in the year. I will mention though some things I think of that are important. We did subgroup the primary outcome in 12 different ways, and that includes people who have a very large BMI, people who are overweight. We did not exclude people for their weight. We did not exclude people with congestive heart failure. Now, if they have such severe congestive heart failure they can't lay on the table for a procedure, though, sure, they got excluded. But so these patients were in the trial, and certainly, no study has the power to address every single tiny little subgroup with statistical power, but these patients were not excluded from this trial. And in terms of obese patients, when we subgrouped the primary outcome there, it did not affect the results. You know, people with a BMI over 30 versus less than 30, over 25 versus less than 25. There was, in terms of the treatment effect for lysis, it did not change things. I'll mention too that the iliofemoral and FEMPOP subgroups, again, we stratified the randomization by that variable and also subgrouped the primary outcome for that and the proportion of patients with iliofemoral DVT. In other words, it extended into the common femoral or iliac that developed post-thrombotic syndrome was 49% in the lysis arm and 51% in the control arm with no statistical difference. Now, again, that's just the outcome of any post-thrombotic syndrome as measured by the Villalta scale. When you start talking about secondary outcomes such as the severity of post-thrombotic syndrome, health-related quality of life, etc., we are in the process of doing that, and certainly, you know, the preliminary look at the results that we've had suggests that there may be something to see there. But I think that until we've really done that and can provide specific information, we don't want to go too far with pronouncing anything in one group or another. But all that information is in the data and will be provided.
All right, so Suresh, I'm going to take the prerogative as the moderator to kind of, you know, call you out a little bit. The question is, what did it not tell us? You just told us all the things it did tell us. Tell me one thing it did not tell us.
Well, I think that, you know, some of the important things would be, for example, you know, what's troubling about this, obviously, is that even with all this subgrouping, these patients, so many of them got post-thrombotic syndrome, and how do we know who's going to get PTS, right? So we're focusing on factors that relate to the anatomy, right, and where the clot is and things like that. But there are undoubtedly genetic factors that play a role here. The ATTRACT trial did not have the budget and did not collect blood samples and that kind of thing. That's unfortunate. I think that, you know, the next trial we're going to do, we're not going to let that one slip. So we can't do genetic testing really in these patients to identify, you know, what causes PTS. How do we get better at figuring out what are the other mechanisms involved? Because you've got 2 randomized trials now, and neither one of them found less than 40% post-thrombotic syndrome, even in the lysis patients, right?
And I think that's one thing, you know, I thought about these questions before. I just kind of bounced them upon you guys. And I actually think what the ATTRACT trial didn't tell us, and also obviously any other trial, it didn't tell us why we can't do any better. I mean, really, with DVT patients, I mean, you know, in both arms, it was 49%, 51% got a post-thrombotic syndrome of some manner, you know, some degree. And I mean, if we were treating a disease, another disease that we only got 50% of the people better, I mean, that's a little scary. So in my mind, it really did not tell us why we can't do any better. And so, I mean, Bill, can we do better, or is this just something that we just accept? People get DVT, they're going to get some element of PTS in 50% of the time. Can we do any better? Or what can we do to identify how we can do better? Marston.
I think the key thing here is what Suresh said about all the other data that they're going to bring to us. My initial answer was sort of facetious in the sense that the pure statistical primary outcome is only a very small slice of what this study and all the data it's going to provide to us. At the end of the day, you know, we can't treat people by prospective randomized trials. We got to treat them as the art of being a physician, and using all this secondary data that's going to come out hopefully will tell us better which patients really might benefit from aggressive intervention and who won't.
I mean, Darren, is there anything we can do to do better in these patients to get them maybe down to only 25% get some form of PTS? And if we can't now, what do we need in the future to do? We need to treat this disease in a better way.
Well, I think when we were looking, like Bill was saying, at the primary outcome in the trial, just for any occurrence of PTS at 2 years, that we weren't able to make a difference. But there are some signals, like Suresh was pointing out, that we may be able to lessen the severity of PTS in certain subpopulations, and I think that's what the additional subgroup analysis of the trial hopefully will show us. But, you know, I think we need to really, you know, figure out what are the best practices here. You know, what are the ideal techniques if we're going to do pharmacomechanical thrombolysis, if we are going to be stenting these patients, which are the ideal anatomies and clinical circumstances and clinical factors to intervene on. I mean, should we only be intervening on the patients who who have the greatest chance to get a really severe PTS? Are those the ones that are going to benefit? So those are the things that we've got to sort out. I don't think that there's no hope. I think that this is the beginning here. And that, we really have to refine our techniques. We really have to refine our clinical judgment and selection for who we treat. I mean, in this trial, like Suresh pointed out, we treated all comers, obese, CHF patients, a variety of anatomies when you included patients basically with femoral popliteal DVT as well. So there's a lot we still need to learn, and I think that's the opportunity. I think there is room for improvement.
All right, so let's talk a little. Raghu, you want to add anything to this?
Yeah, as the token medical guy in the group here.
You're not the token medical guy. You are the medical guy.
So, we all have seen, people come in, we swear that it's post-traumatic syndrome. We do venous insufficiency test. We do, IVUS, we do angiogram. We'll find these patients who we swear that are post-traumatic syndrome or venous insufficiency-like patients, but everything turns out normal, right? We all have seen that patient, correct? And it's not uncommon. I see these patients every single day of the working week, venous insufficiency patients, and at least 1 to 2 a month is completely normal, right? 30 BMI is great, but we living in Midwest, Darren and, Steve, different story, but Bill and, Suresh, 30 is normal in the Midwest. So, this morning I saw 270 BMIs. So, what I'm trying to say is I think after this trial, Suresh and his team had this powered for 30% PTS rates and with a reduction of 10%, correct? Am I correct, or 20%?
It's a 1/3 reduction from an assumed control arm of 30% of 30%, which turned out to be a bit low, obviously, right?
Exactly.
So the power was plenty.
Exactly. The power was plenty.
Yeah.
Design was perfect in my mind. For the contemporary, design, when you started out, Suresh, maybe 2005, 2006, it was perfect. Okay, couldn't have gotten any better. So why, with close to 50% of femoral popliteal disease involved, why is there 47, close to 50% post-traumatic syndrome? To me, it tells me that probably open vein is not all enough. There's probably something more to it. That's my take with the whole thing. Although we got it powered, very conservatively, done excellent trial, we still have 47, 49% PTS, even though we have femoral popliteal disease involved. You would expect that PTS rates are going to be lower if you involve femoral popliteal disease, right? So why is it so high? What I learned from this really is open vein hypothesis probably doesn't work. There's a lot more to it, and we need to understand more about being.
Well, I'm not sure I would go that far. I'm not sure about that. I think we got to admit that although thrombus clearing was pretty good, it was 75, 78%, right, Suresh? And only about a third.
I think, remember, the mean residual clot, right? The Marder score was 2.7 on a scale of 24 points. So if you kind of normalize that out, it's about a 12% residual clot. If you compare that with the National Venous Registry of 20 years ago and the Covent trial, they were around 10%, and this is about 12%. So it's really not far off. And those trials, they infused for another day beyond what we did in this trial, right?
But still might do better with newer techniques, or if we can deal with older clot better. I think some of these patients probably fail because the clot is a little on the old side. And then the other issue is, did we stent enough patients? And that's something that, now it's more routine to do that. But I think the good question is going to be, will you be able to tell us from the data whether these patients are getting PTS due to residual obstruction or is it reflux, or both?
Sure. So these are great questions. So I'll mention regarding the open vein hypothesis, if you take a look at table 4 in that paper we just published, at every time point that we studied, using both the Villalta scale and the venous clinical severity score, the mean scores were lower in the patients that got lysed, better. Okay? So the idea that the open vein hypothesis has no place, I would find that hard to believe.
No, I said
now,
that.
Yeah, Raghu, go ahead. Wait, let Raghu, because that's not how I interpreted what he said. Raghu, clarify what you said.
Yeah, so what I'm saying, Suresh, is I'm saying open vein is just not enough. Maybe there is inflammation to it. Maybe there are other factors. What I'm trying to say is we're still at a stage we need to learn more about venous disease, is what I'm saying.
And we agree there, absolutely.
Yeah. So what I'm saying is, let's just assume you had 100% iliofemoral DVTs and not 50% femoral popliteal. The PTS rates would be anywhere higher, over 47%, if the trial were conducted as is. Am I correct or not?
You mean if you're only looking at iliac DVT?
Yeah, I mean, if you just had about 50%, femoral popliteal, right? We all agree that PTS is worse as we get higher, right? More proximal. So if, let's just say you had 100% iliofemoral DVT in your trial, okay, both arms, I would expect the PTS rates to be more than 47, 50%, right? You guys agree with that?
They're a little bit higher. You have to remember something else, is that, remember, there are patients lost to follow-up.
Sure,
and people who are lost to follow-up, they can't be counted as PTS. Right? Only when you do the imputation with multiple imputation, right, and you try and account for that, you end up with something around 60% for the iliofemorals.
So no, I understand, but what I'm saying is, if anything, the enrollment of femoral popliteal patients has gotten the PTS percent down, is what I'm saying.
He's saying that if you had a pure iliac DVTs and you excluded your fem pops, your PTS rate would be higher.
Even in the treatment?
We know it. Well, I mean, we know what it is because we know what it is in the iliofemorals, right? I mean, that's what I'm telling you. It was 60%. Right.
So that's what Raghu is saying. It will be higher.
And that begs the question again that Steve asked, like, is that enough? 60% of patients with iliofemoral DVT, even after treatment, having 60% risk, chances of having PTS. So that's where I'm coming from. That open hypothesis, open vein is not enough, is what I'm saying. There's something.
It's just part of the story.
Right.
Absolutely. Yeah, I think that is very clear. And that's true from the COVENT trial too, right? 41% of the lysed patients got PTS, right? So there's obviously other mechanisms at play that we just haven't really worked out yet, and they also need to be investigated.
So I want to go to, remember, the data you collect, then you analyze the data. I want to ask, what do you all think about the definitions that we use, Villalta score, whatever, to define what, quote, PTS is? Do we need to come up with a better way of really measuring, PTS and how it really affects the patient, or are we comfortable with the measurement tools that we have currently? And Darren, maybe you could give me some ideas about that. I mean, is this as good as we can get? Is this a realistic, real life thing for the patient, the Villalta score of VCSS? For DVT, I'm not talking about for venous disease in general.
Yeah, I'm not sure for DVT. I mean, I'm certainly not an expert in these scales and grading and Villalta and these grading scales. So some others may want to chime in and add their expertise. But I think that could be, one of the issues, that was the endpoint here. Maybe it's, too sensitive for certain things. Maybe that's why we have such a high percentage of patients positive for PTS. I mean, I think that, there was a signal in some places that in terms of looking at the incidence of moderate to severe PTS that was reduced. And, getting to the comment that open vein is not enough. I mean, I guess I'm getting off topic here, but there's other issues with compliance with compression therapy and the post-treatment modalities, that it may be that you need the procedure and you need something else, but maybe we need to also, getting to your question, maybe we need to be able to measure it better when we're talking about PTS and how much benefit or lack of benefit patients are having with our interventions.
Yeah.
You know, Steve, I think this is another place where the study will help us out because we've measured quality of life. We've got Villalta, we've got VCS. We can start to look at what really matters for quality of life, and do we need a better cut point or a better scale?
Right. And,
And
go ahead.
that part of the plan is to do that. And I'll mention too that, when we looked at the primary outcome by VCSS, by the cutoff point of 4, there was no change in the findings of the study either. One thing also that people are doing in other kinds of studies, which is interesting, if you think about it, PTS is a disease that occurs every day to a patient, but we measure it 3 times or 4 times in a 2-year period for the study, right?
Right.
But there are ways to do what's called experience sampling, whereby people nowadays are using kind of their smartphones and mobile technology, their watches, to record their symptoms on a daily basis and submit that into a data center. And people are validating that kind of thing for different kinds of chronic diseases. And I think that for something like this, that might be an interesting tool to use, in future venous disease studies.
I think you're absolutely right. That's truly the thing. I have a patient who wants to be able to hike up a mountain. Got another one who needs to do his job as a night watchman. That's what matters to them.
Right.
Malta.
No, and Bill, and I will agree with you on this. And then Raghu, I'll let you talk in a second. I mean, sometimes I do all my VCSS and everything on my patients, but also a question I ask them all the time is, hey, how you doing? Are you able to do whatever you want to do in your life? And if they say, yeah, I'm all right, I don't care what the VCSS says. And I think that's such a gross way of looking at it. But actually, what Suresh is saying, if on a daily basis, if you ask a patient, if they say, hey, doc, I feel great, I don't care what the VCSS is or the Villalta is. And like you said, Bill, it's about what that guy or that woman or whatever wants to do in their life. It doesn't matter what that number is on a Villalta score. Raghu, I'm sorry. Go ahead.
Yeah, like I started in my opening, statement, I personally don't believe that any of these scores are specific. I take Villalta and VCSS scores in my patients with venous disease, whether it's PTS, whether it's chronic venous insufficiency from reflux, whatever. Ultimately, it's elevated venous hypertension. If you take right heart failure patients with tricuspid regurgitation, we'll get exactly the same symptom.
Yeah.
So these are not specific.
All right, let me change a little bit, guys. Let me talk about, we mentioned briefly about technique. What do we need if we assume, let's assume part of, and I'll say this, part of improving a patient with the DVT is to get the vein open. What do we need from a technical viewpoint that's better than what we have now? In other words, what modifications, what new technologies do we need to get more veins open and to stay open? And so, Darren, let me go to you because you're big on technique and you do a lot of this stuff. What is lacking in the technologies we have now, and what do we need?
I think there's still a lot of room to have a better thrombectomy device for these large veins that we're treating. I mean, when we start talking about some of the angiojet catheters and devices like that, yes, we can remove thrombus, but how how complete are we able to achieve thrombus removal in a large venous system? A lot of times we're having to resort to the adjunctive lysis, dripping patients. And so I think there certainly is room for improvement there. Devices also that can do it without damaging valve leaflets and with minimal trauma to the veins themselves while still being able to completely evacuate thrombus. I think that those may be some of the keys going forward. So there's definitely room to improve and iterate on the devices that we have. And I think even beyond devices, there's room to standardize and optimize techniques. I mean, I think when this trial got started, I mean, we have to remember this trial started in, when did this get going? I mean, we started putting things together in 2005, 2008. This was really early in a lot of people's experience in some of these techniques. So I think there was probably a lot of variability in devices that were used and even the actual technique that was utilized.
Yeah. Suresh, let me just ask you a side question. Did some centers get better results than others And I'm particularly talking about technique. In other words, were some people better at getting clot cleared versus others?
Well, there's a distribution, and the thing is there are 56 sites. So if you think about it, the average site only enrolled around 10 or 11 patients. So when you start saying, can you do any statistical comparison of site to site, that's very hard, right? But there's certainly a broad skew of clot removal in patients, right?
But Suresh, please get away from the statistics. I mean, you know me a little bit. I want to get more to just your gestalt. Your gestalt was, hey, did so-and-so do a better job than so-and-so? And you don't have to name anybody. And this goes to Darren's point about
go ahead, sorry.
This goes to Darren's point about technique. Listen, there's no question some of us are better than others in doing things.
Sure.
So I want to know, what were the best sites? What did they get in terms of clot clearance versus the sites that didn't quite do as well? Can you identify people?
We didn't do any kind of analysis like that.
But wouldn't that be nice? Wouldn't that be nice that you could ask this guy or this woman, hey, how come you got this clot clear? What are you doing different than another person? And we can learn from this. We can all get to be the best of the best that was in your trial.
Sure. I think you're making an assumption, though, that the amount of clot removed is solely due to the operator, right? There's a number of factors that might be influencing that go beyond the operator.
Yeah, I know.
And if you're talking about comparing with these kinds of numbers, you have to be a little bit careful about over-interpreting what you're comparing. Now, we are, going to be reporting some specific techniques out. For example, the use of the power pulse technique, the use of the trellis, which is not really that relevant anymore. The trellis isn't, but we will be talking specifically about those in future papers. But I'll say this, I mean, the amount of clot removed was very much consistent with what's been seen in the literature since the start of this procedure. In terms of technical refinements that occurred after we started doing this, I think the one thing might be IVUS. Intravascular ultrasound was used sporadically by some people, but near the end of the trial. But I don't think most people had it as a routine practice. And I think also IVUS is just used more for chronic than acute patients in general. And so, that's probably the one thing, but that's not something that had ever been used before really regularly either, right?
Right.
So, that might help a little bit in identifying a few things that might have been not seen probably, but that's probably the one technical thing that really changed, over the last 7-8 years, that maybe in a more meaningful way.
All right, Bill, talk to me about technique because sorry, Darren, did you want to say something first?
Yeah, and getting that point about IVUS, I mean, I personally think that IVUS is a real critical tool to use when you're doing these venous interventions, because if you leave a residual stenosis, whether it's from May Thurner or some, chronic thrombus somewhere, those patients are, at least in my opinion, are more apt to fail. And then when I looked, I think in one of the tables in the paper, there was all the different types of stents that were used. There's a lot of variability there. The patient had a Viabahn. There were a lot of slotted tube nitinol stents. There was, the largest population was probably with wall stents, but there was a whole lot of variability. So the stents and equipment that were used, the type of thrombectomy devices, whether or not they used adjunctive IVUS imaging, I think there's a lot of room to learn and standardize and identify what the ideal or best approach is to these patients, and we can, hopefully there's something in the data there that we can look at and learn from as well.
Yeah, Bill. No, Darren, I agree with exactly what you said. Bill, talk to me a little bit about technique and what are we lacking currently in technique, and what do you feel is the optimal technique in 2017 for clot removal?
Well, I think the biggest challenge we have right now is definitely, clot that's a little older. I mean, if the clot's really fresh, so they're within the first few days, you can do anything. I mean, there's 3 or 4 different methods that are going to clear that pretty quickly. But we see a lot of patients, and it's going to probably be more based on the results of this trial, where they get sent out of the ER, they show up at their primary 2-3 weeks later, and they're very symptomatic. They're like, you gotta do something. And then they show up in our office, it's 3 or 4 weeks later. And we're not very successful then. And so, a technique that works on that older clot is really going to help us out with these patients. I think, Suresh, you can correct me if I'm wrong, but those patients who are more symptomatic early on tend to have a higher rate of PTS.
There was a little bit of a trend in that direction. Yeah, it didn't reach statistical significance, but there was a trend that the people that had the highest Villalta scores up front, might have done a little bit better. Yeah.
All right. So now, Raghu, once those of us who are surgeons here, interventionalists here, clear out the clot, what is it that medically you feel is going to optimize that patient for getting the best results? I mean, what are the things we need to keep in mind?
Well, thanks for asking that. I was going to wait for my turn to.
The reason I asked that was you were so quiet, and I cannot ask you about thrombectomy because that's not what you do. But you're the expert in this side of the thing. So tell us.
So every major trial, ATTRACT trial and SOX trial, looked at compression therapy also. Everyone got the compression socks. Now, that's not how vascular medicine folks are trained. We are trained to put medium stretch compression wraps. I'm sure the vascular surgeon is the same way, to reduce the size of the leg first, and then put them in the compression socks. Ideal studies, they study ongoing. I think it's done now. It's a Danish study, I believe, where they did the same as opposed to the SOX trial and the ATTRACT trial. When you fit somebody with a compression sock, you're fitting them with that circumference, right? That compression sock is not going to bring it down anymore. That just does not make physiologic sense. So what we train our nurse practitioners is to, wrap the leg from the foot all the way to the thigh, okay, for at least 2 to 3 weeks until they come back to see us, at which point then we, measure them for the compression sock. It makes sense that, you need to get that inflammation down, the swelling down, that venous lymphatic pressure down, and then, get them into compression socks. Again, that's the way the ideal study is designed. I'm just waiting to see the results. They're not out yet.
Yeah, no, and I think you're right about that, and that goes to the point that what we're all saying is that the open vein is not the only thing, as you have been highlighting. It's all these adjunctive things. You need to open a vein if you're going to wrap the leg, because if you're wrapping against an occluded vein, it's not as good as an open vein.
Right.
But I think you make an excellent point that, quote, compression stockings is not the first thing you go to. You really got to get that swelling down. Now, Bill, I mean, you clearly use these kind of wraps and everything in the wound patients. Do you use these also in your thrombotic patients that you cleared out clot?
Yeah, initially we do, to get them down to normal size. So we'll do that, usually for a few weeks or longer if need be, and then switch to compression stockings.
Yeah. So, Suresh, let me ask you, when you were conceiving the trial, were you thinking that we need to standardize therapy, or it was like let them do whatever they want to do and let's see where it goes? Yeah, I mean, did you have that kind of discussion? Like, no, we want everybody to do it this way because this is, quote, the best way that the literature is telling us in 2005, 6, or 7, whatever the hell,
Yeah. So remember that when we started the ATTRACT trial and designed it, there were a couple single center trials that suggested that compression stockings reduced PTS by 50%, right? And I think it even had a 1A recommendation on the part of the ACCP. So with that in mind, we said that at 10 days, all patients will be evaluated and measured, and at the 10-day follow-up visit, size to fit compression stockings were applied. We used a uniform brand, BSN Medical's compression stockings, and we used 30 to 40s. And that was in an effort to be uniform and to reflect, previous studies. Now, subsequent to that, the SOX trial came out. After it came out, we thought, well, should we modify this or modify that? We thought, you know what? If you start modifying things in the middle of a trial, you have no idea what you did and what you're dealing with. So we continued the approach, and we didn't see any downside to putting stockings on. But we did not have routine wrapping. We did consider it, but the problem was that, again, the heterogeneity in doing it. And then also remember, we were trying to minimize the fact that people in the lysis arm are, I guess they call it observation bias, right? They're in the hospital, they're being seen, and they have more attention from providers up front. Whereas people in the control arm, many of them were just discharged, right? So in terms of applying compression and monitoring it and that kind of thing, we were a little bit concerned that if we apply wraps, one, it wouldn't be done homogeneously. People would use all kinds of products and this and that, and we couldn't really reasonably standardize it. And then secondly, you might get some kinds of bias introduced by the fact that you've got one group of patients in front of you and the other group you don't have in front of you.
All right, so that kind of explains it. And that kind of moves into another question that I have written down here, which is, if we were starting a trial today to answer the same question that you tried to answer, way back when, what is it? How should we design the trial now in 2017 to answer the same question, which is, what's better, lysis or anticoagulation? So I want you guys just to kind of think about that. What elements, knowing what we know now, and Suresh did not know a lot of the stuff that we know now. I mean, a lot of time has passed when he first started thinking about this trial. What kind of trial would we or could we design today to answer the question, anticoagulation alone or lysis plus anticoagulation? What's better? So just ponder that for a moment, and then I'm going to, if nobody jumps in, unfortunately, I'm going to have to ask somebody.
I could talk for 30 minutes, but I'll wait.
Suresh, we'll let you start because the other guys, I can see the way they're looking here. Their mind is working. So Suresh, give us the 3-minute, and literally, I mean, the 3-minute, what kind of trial would you design today versus when you started?
Sure.
To answer that question.
So I think from an eligibility standpoint, I think that you want to focus on people with the most significant, we'll get the specific data out of ATTRACT, but I think that it would be people who have common femoral or iliac thrombosis and who have the most severe symptoms, I think that that's going to be important, really. I think that in terms of designing the trial, I think you still want a randomized design. I think you would look at severity, disease severity, and that could be measured in different ways, but health-related quality of life is a very important part of that, I think. And when we subgroup that outcome, I'll be very interested to see what we find. But I think that it's going to have to be severity-based, not necessarily a binary kind of outcome.
Okay, so anybody else have any other thoughts? Because I got a lot of thoughts on this.
Well, let me challenge the model itself. We had EscharERA trial, which is a randomized controlled trial. Then we went to EVRA trial, which we are all eagerly waiting, which is a single-arm prospective study, as all of you. Would any of you start enrolling patients if we, start a clinical trial to treat patients with Coumadin, heparin, and Coumadin on one arm and nothing in the other arm? There's only one trial for heparin, that randomized patients, 16 and 19 patients, and there is no randomized controlled trial for Coumadin. So ACCP guidelines up until the seventh guidelines still used Coumadin and heparin as grade 1A, and I think 8 turned it down to whatever it is now. So what I'm trying to get at is, when there is no equipoise in the treatment, when we know that one benefits the other, I don't know if randomized controlled trial is the way to go. That's what EVRA is doing because, EscharERA failed. I don't know what the answer is. I'm not a trialist, but it just does not make sense to me that, the ATTRACT trial enrolled every consecutive young patient to old patient coming in with iliofemoral DVT. There is that enrollment bias of, I don't know what this patient is going to be. Let's enroll them in the trial. That's how Coral died. That's how Crest died. Interventions, and I don't know what the answer is, but should there be another EVRA kind of trial for ATTRACT to follow? I don't know.
Can I say something about the equipoise point? I mean, it's a great point, and I know with Coral there were a lot of very clear-cut and demonstrable issues there. We worked very hard in the ATTRACT trial to avoid that very problem, and every site investigator got calls from me and from others talking about the fact that we need to be absolutely inclusive when it comes to taking people that meet the eligibility criteria, putting them in the trial, even to the point where we had them document how many people did you lyse off study, during this period. So we were following that also and continuing to have communication with the sites on, okay, well, why did you do that? And also training on how you present the study in a balanced way, because we all know that we all have our internal biases. And we put them through an awful lot of effort to avoid that very specific issue because of that concern. Now, I'm not going to say that we could stamp it out totally, obviously. It's certainly possible some people stayed out of the trial either because they were deemed less safe candidates for lysis, or because they were deemed to be such clear-cut lysis candidates that whatever. But I think it's a lot less than what you might expect because of all the efforts that were put in.
I know you did everything in your hands, trust me. You dedicated almost a decade of your life. Kudos to you. I've always said that. But it's still hard to change physician bias in practice.
All right, so wait, let me
Go ahead.
let me go to Darren. So Darren, talk to me about if you wanted a trial to answer the question, what should we do? Anticoagulation or lysis? Give me what you would do today to answer that question, or some of the aspects of it.
Well, I think the first question is getting back a little bit to what Raju was saying. Is it going to be feasible, really, to redo a total prospective randomized trial? But if I were to do it,
Darren, we're talking in the esoteric here. Forget
yes.
about if you had unlimited funds and everything else, what do we need in the trial to answer the question?
Yeah, I think we need to first, complete the subset analyses in ATTRACT to learn as much as we can. I think we need to know really what is the appropriate target population, because I think the fact that we didn't find a difference with the ATTRACT trial suggests that treating all comers is not the answer, and we got to identify who the population is who's likely to benefit. And I think we know that, or we at least have signals in that direction, that those are going to be the patients with the most severe DVTs with the biggest chance of getting PTS. So it's going to be those patients with iliofemoral DVT, and they really need to have significant pain, and they also need to have significant swelling, I think, to derive maximal benefit from the intervention. And to Bill's point, I think we also need to make sure that we're getting these patients early when we're likely to benefit by removing the thrombus and able to do it effectively. And then I think we have to couple that with best practices that we can learn from the trial as well. So we need to standardize how we're doing imaging. If IVUS is the best way to image, then IVUS needs to be incorporated into the trial. And then I think we need to standardize, how we access the patients to gain our percutaneous access. What are the best techniques and devices to use for mechanical thrombectomy, and make sure that that's standardized. And then that also has to go for, I think, the post-procedure treatment. And I know that was done in ATTRACT, and Suresh did a great job with those things, trying to standardize everything, but we've learned a lot since then. I think we need to take, those things that we've learned and then really target the population who we think is going to benefit with the best practices that we think are going to be effective, and then test that.
Yeah, I think that's a good summary. Bill, what are you thinking?
Well, I think that the data, as Darren said, the sub-analyses and the specific reasons why patients failed is going to be critical. So if we find that they're rethrombosing, then we need to do a better job with the outflow. We need to maybe use IVUS routinely. And think about it, in 5 years from now, we'll probably have a whole different slew of devices and methods that we can use. If they're failing because of reflux, then probably earlier treatment. Then maybe we have a reflux device we can use in the future. But I would look at the trial in that sense, that you're going to have a whole new wave of therapies not too long from now to employ.
Yeah, I mean, to me, to kind of summarize it, I mean, we've broken it up into identifying those people pre-treatment that we really feel, based upon what the ATTRACT trial is going to tell us, that are really going to benefit, and then standardizing the treatment. And saying, look, if you're going to enroll in this trial, this is what you need to do when you have a patient that's a candidate to be randomized. And if you're going to do pharmacomechanical thrombolysis, this is the way you do it. And this is what you need to, whether it's IVUS or whatever the heck it is. And then post-treatment, to Raghu's point, is the type of compression and post-treatment care. And I think, you know, standardizing it to what, as Darren said, the best practices in 2017 or 18 or whatever, is something that maybe can narrow the focus. And Suresh, I think what the ATTRACT trial is going to identify, and everybody said this, is give us the people that are really going to be the best candidates, and let us not waste our time on those people that are not good candidates. And let us really focus on those people that we can truly, truly help, and standardize the care going forward as to what we need to do for those people that we can help, so that hopefully we're not talking about a 49 to 51% rate of, you know, post-thrombotic. We're talking about a 25% or a 20% rate, if we can do it that way.
But maybe it's also not the, you know, also how we're measuring it as well. Like everybody commented, I mean, maybe it's not Bellotta, but maybe we need to know, you know, the time to resolution of symptoms, how soon people were able to return to work and normal daily activity. Were they able to return to work versus not being able to return to their normal work? I mean, that may be important in some minor differences in the Bellotta scale. In patients.
It's all coming too. That, you know, the secondary analyses, cost effectiveness, cost, all that stuff is, you're going to get that soon. I'll mention one other factor that we didn't talk about, which is that, you know, what shocked me in this study is that, you know, the iliofemoral group didn't do better, right, with lysis. And one thing is that, remember that in a study like this, when you're enrolling them, we're using iliofemoral as a surrogate for lots of clot or extensive disease, right? And really, though, if you had a 1 centimeter clot in your common femoral vein, you're iliofemoral. If you have a 20 centimeter clot in your femoral popliteal segment, you're fem-pop. And so you got to be a little careful. And remember that, you know, in this study, the whole point is that this is a first-line treatment population. It's not like what we get in our clinical practices, where the medical physicians screen out the ones that respond to anticoagulation, then send us the ones that don't, right? That's what our practices are, right? In this study, though, we enrolled people that really get treated with medical therapy, the clot goes away, or their symptoms totally resolve, and they never get referred to us, right? So I think that in addition to iliofemoral fem-pop as segments, I think that really getting a better sense as to, you know, what clot extent predicts, you know, predicts PTS, doesn't predict PTS, showed a bigger, you know, I think those kinds of questions can help us, you know, pare it down further and get to a, so hopefully, I hope there will be another randomized trial, but I hope it's focused really solidly. We have a really solid target for the next one.
Yeah, and I think that, and I think that's one of the points that comes out of the ATTRACT trial, is that you are going to, you know, give us data as to where we really need to focus on, which patients we really need to think about helping, and which ones don't even think about it. Just put them on anticoagulation, and they're going to do just as well as if you did something.
And think about endovascular stroke care as well. I mean, the first big NIH trial was negative. 2 other trials were negative. Okay, right. The thing was dead. Right. Then the devices got innovated. They decided, okay, what's the anatomic treatment? You know, who should you be treating? And then boom, 3 positive trials, and now it's the standard of care. So hopefully, someone else will come around and continue this and really use the data, you know, effectively to do that.
Yeah. So in other words, once you tell us, or once the ATTRACT or whatever tells us what are those patients that need to be intervened on, then industry and doctors and everything else are going to create technologies and techniques to deal with those patients that are truly identified as those that need some type of intervention.
So to that point, Suresh, is there a way that you think, from all the data from this trial, that you can classify patients not anatomically but based on the extent of thrombus burden?
Well, I think the challenge, of course, is that iliac segment, right? You know, the common femoral and femoral are easy, but I think you'd have to have all the patients imaged, right? Using some type of cross-sectional or whatever imaging up front.
Right.
Yeah. You know, and in the ATTRACT trial, we don't have any assessment of the iliac vein in the control arm patients, right? Mm-hmm. You know, they got ultrasounds and they got in the study, basically. So we don't really have that. You know, we have common femoral assessments, but we don't have iliac vein assessments. So it makes it a little bit harder to do that.
Hey, Suresh, a quick question. Knowing what you know from a ATTRACT trial, what would be your, if you had to redesign it, what would be your primary endpoint? And do you think, like stroke studies, would NIH eventually sponsor another you know, ATTRACT-2 trial, if you will?
I think, obviously, with NIH it's always hard, but I think they would, first of all, because I think the awareness is there. I think even our project officer recognized that, if you look at those secondary outcomes, God, we've got a whole data report, and you look at these secondary outcomes, everything related to symptom severity, it leans one way. Now, the problem is that we're dealing with TPA. And so leaning one way or having a small difference ain't enough to say you can treat 100,000 people with lysis, every year and take the complications, right? But I think that clearly there's something to it. I think they can see that as well. So I think in the right scenario, if someone proposed a great study, I think they would. But it has to be done, obviously, and it has to be targeted, but I don't think it's closed. And I wish industry would do it, although I realize that with industry, it's probably a harder, heavier lift at this point, at least.
What about the primary endpoint?
Tougher, because I want to see more data as well, because we've been looking at these symptom scales, but we all know when you look at the elements of those symptom scales, you're like, pins and needles, or, you're kind of like, well, yeah, they count, but I mean, because there are other ways to go about it and just say, should we just look at pain, or something like that, right? Or should we just look at health-related quality of life? Now the NIH is not fond of that sort of thing because they see a quality of life measure, any patient-reported measure, as connoting, in an open-label study as bias, right? Unless you can blind the participants, then you've got this potential for reporting bias. So they don't really like that. And for example, for CTRACT, the next trial we're doing, we proposed quality of life as our primary endpoint, and they nixed it. We had to come back with something else. But at present, we're sort of stuck with what we've got, but I do think that experience sampling is the way to go. That needs to be explored and validated, and I hope someone kind of takes that bull by the horns and does it.
Yeah, because in the end, and really, I mean, I don't know about you all, but when I see patients, whatever intervention I've done on them, I mean, my question to them is, how's it going? How do you feel? And if they say fine or great, that's enough for me. I don't care what the number says. As Bill said, the guy who wants to climb a mountain may be different than the person that just wants to be able to go shopping and get their groceries. And to me, I don't know if we have some health-related quality of life issues, but I mean measurements. But it's almost such a simple question that we sometimes make too complicated. If you say to the patient, hey, you able to do what you want to do? You're feeling pretty good, and they say yes. That to me is a positive result. I don't care what that number is or what that VCSS or the alpha is. And I understand that's a very gross and non-scientific way of looking at it, but it's also a very practical, in everyday life kind of question to ask people. And so endpoints are always very difficult, and we all like numbers, and they're great. But do you ask a patient when you see them, what's your VCSS now compared to when you say, if they say to you, hey, I'm feeling good, great, thanks a lot, I'm feeling good, you're feeling good yourself. So I don't know what the answer is. We need numbers. NIH is never going to go on hey, the patient said they feel good kind of thing. But in the real world, I mean, that's really what it comes down to when we talk to our patients. Well, what do you guys think about that? Darren, you're nodding your head.
Yeah, no, I agree with you. I mean, I don't think it's the patient. If you tell the patient that we're going to see whether your Velada score gets better, they're going to tell you that they could care less. Exactly. So I think we really, probably do have to look at, some patient-centered outcomes and maybe define what's important. Maybe there should be patients involved in the focus group to try to identify what are going to be the important things. But I agree with you. I mean, maybe we're just not measuring what's the right outcome in some of these patients. I guess the other question, moving along a little bit, is in the aftermath of the ATTRACT trial. I mean, in everybody's opinion, who should we be treating with intervention? At least I know in my practice, it's still going to be the patient with really, a proximal DVT who has really severe symptoms and who otherwise was fairly functional before that and has a lot of potential disability with post-thrombotic syndrome if you don't intervene. and they don't get better with anticoagulation alone. I don't know, should we anticoagulate them for a few days first and see if they start getting rapidly better before we intervene? Or, so I think that there's a lot of questions. I still think there's a place for intervention, at least personally, and I'm going to be selective, but I'm going to be still doing it.
Yeah. So Darren, so I mean, we're getting down to the hour, and we like to keep this to about an hour. So you actually, I did not share my questions with you, but that was my last question, which is.
Oh, I'm sorry, I didn't want to preempt you there.
No, that's good. I'm glad somebody else is thinking like me. You're exactly what I was going to ask everybody is, what can we, those of us here, give to the everyday practicing, IR, vascular interventionalist, whatever? What are the practical suggestions that we can say, here's where we feel you should intervene, here's where we feel you don't need to intervene, and here's where we don't think you should. And you clearly outlined your thoughts about where you think we should intervene. Could anybody else, let's give our readers or the people that are going to listen or read this, from a practical viewpoint. You see a patient, what are those patients are going to say, I want to intervene, and what are those patients going to say you're not? Somebody, if Darren already elucidated what he thinks, and I
think Darren got it pretty much right. It's the younger, more active, and young doesn't mean age. It's, young in terms of their activity. The patient has a lot to lose by getting significant PTS. And then you got to really do a good job of consenting them. They've got to understand what the options are. I think the good thing from the trial is that the rate of major bleeding was quite low. It was higher than the control group, but it was low. So you can give them that information, but they got to understand that there are other complications other than bleeding that can occur. But if they're committed and they tell you, Doc, I want you to get that stuff out of there, which a lot of them do, those are the patients that I would treat.
Yeah. Raghu?
Yeah, the same thing. Young iliofemoral DVT with low bleeding risk. Yes, although the bleeding rates compared to CAVAN trial have been quite low. With the ATTRACT trial, it's going to be lower with the the newer thrombectomy devices. Hopefully, that can debulk and use less lytics. So yes.
Right. All right, Suresh. Don't tell me anything about the trial. Tell me about the next patient tomorrow that you see that has a iliofemoral DVT. What is the one that you're going to intervene on, and what is the one that you're going to just put on anticoagulation? So
severe symptoms after probably about 5 days of anticoagulation, less than 65 years of age, low bleeding risk with clot in the common femoral vein or above. But I think the key point there was that I'd anticoagulate first for at least a few days, knowing that some people just do melt their clot, Many don't, but some do, and sometimes it's a shorter clot than you think. If that's the case, then maybe that patient doesn't need lysis. So really, it's more of a second-line use. It's for first line, it's really if they have acute limb threat. But for the most part, I see no reason not to anticoagulate people for a few days first.
All right, good. All right, so everybody, I mean, we're into the hour and stuff. And first of all, I want to tell you, I mean, Suresh, I mean, your trial, allowed us to have this entire conversation for this hour, and all of us think it's just absolutely great what you did and the effort that you put into it. And I want to thank everybody else and Suresh for all of your theoretical but also the practical thoughts about the trial and what it told us, and then practical thoughts about how to manage at this moment in time acute DVT in patients. So unless anybody else has some burning issues, Darren is still in his tie and he's still at work. We have to get him home. If not, I really want to thank you guys. I mean, I think it was a great discussion, and I think people can get a lot out of this. So I mean, I want to thank you seriously.
Well, thanks for setting it up, Steve. I think it was.
Thank you very much. It's a great opportunity. Thank you.
All right, guys. Take care, and then. So you're going to get a whole transcript of this, and you're going to be able to edit it and stuff, and before anything is put into print or anything's put online in terms of the video that was recorded. All right, so thanks a lot to everybody, and happy holidays too.
Happy holidays to all of you.
Happy holidays. Have a good night.
So long.
Bye-bye.
Bye-bye.